Welcome everyone to our June 2024 meeting, where we have an eminent expert on liver cancer to talk to us. She is Professor Helen Reeves, and she's based at the what used to be called the Old General Hospital. It's now the Cresta Clinic and the Centre for Life. She's also a senior lecturer at Newcastle University. So without further ado, I'll hand you over to our guest speaker, Professor Helen Reeves.
Thanks very much, John. Now I have got some slides, so I'm just going to share my slides, if that's okay.
Yeah. They're perfect. Can everyone see those?
Yes.
Yeah, excellent.
Okay, now I'm just going to basically go through some of the background for liver cancer, some of the things that have changed, and what the treatments are that we're using at the moment for patients. I'm very happy for anybody to jump in with a question at any stage. So I will kick off. When we're talking about cancer, the thing we always are aware of is the stage of a cancer. Now, you will have listened to other people talking at these meetings and know what an organ looks like. And then as you get disease, whatever the cause, the liver becomes scarred. And it's within that scarred liver where you've got nodules in a cirrhotic one, where these can turn into cancers. And a cancer can be a small cancer, or it can be a big cancer. It can be on one side of the liver, or it can involve both sides. And down here, we've got a fatty liver, because a lot of us are interested in fatty liver disease. And now when you get a cancer, it's partly because of the cirrhosis, but we also know that in that cirrhotic liver where there's all the injury, it's the immune response. It's all of the immune cells there in your liver that should be preventing cancer. They should be removing cancer cells. And when you've got cirrhosis, they don't work so well. And we know that this is part of the reason people develop a cancer. But whatever the type of cancer you have, what's important, slide isn't quite advancing. Hang on. What's important is what we call this stage of the cancer. I just need to try and work out why my slide is not advancing. Let's try again. Okay, there we go. So when we're talking about a cancer stage, what we mean is it just one cancer? Is it two? And how big are they? Have they invaded into something else? That means you can't cure them. Have they spread outside the place where they started? So have they metastasized? And in the case of the liver, that means have they got extrahepatic disease? So those features are important for any kind of cancer when you're thinking about the treatment. But we know that for people that have got liver cancer, because the majority have cirrhosis, the liver function is equally important. There's no point doing something to a person that might shrink their cancer if actually it makes their liver function worse, because it's their liver function that is going to determine how long they live. And if we look back over the last, this is 30 or 40 years of what's been going on in the world of liver cancer, over here on the left, and this is how we've developed the diagnostic strategies, understanding how liver cancers develop and progress, the different treatments, and then surveillance as well. So really in the 1980s, on a global scale, we were looking at cancer caused by viral hepatitis in Africa, Asia, Europe as well, hepatitis B and hepatitis C being the commonest causes of liver cancer. And so all of the people working on liver cancer were looking at those types of people who had got viral hepatitis. Now, here in red, this is the BCLC. So in Barcelona, there's a big group of people that have worked with liver cancer for years who have come up with the Barcelona Clinic for Liver Cancer staging system, which incorporates those features of tumor size and number, but also the liver function to help people choose treatments for patients. Now, you can see that here in 2002, 2003, in the yellow box, that's when we first recognized NASH as a cause of liver cancer. And you will have heard other people talk about NASH. This is now called MASH, metabolic dysfunction associated steatohepatic liver disease. It's basically fatty liver. And this fatty liver, it's not really come along as anything we've recognized until after all of these studies, which contributed to the development of the staging system that helped to choose treatments. And actually, it didn't really matter very much in the earlier days because there weren't many treatments. If you had a small cancer, you were either going to be able to have an operation. If your liver function wasn't very good, you were either going to be able to have a liver transplant or not. There weren't medical treatments. Oncologists were never interested in liver cancer because there was such a limited role because of the cirrhosis. And round about 2000, there became available another arterial treatment. Actually, in the last 10 to 15 years, this has all changed. Even for people with advanced cancers, there are now medical treatments available. And this has become something that is changing outcomes for our patients. But again, the people going into the clinical trials, and I'll tell you why in a few more slides, they tend to be those that have got viral hepatitis rather than those with fatty liver disease from either being a bit overweight or taking a little bit of alcohol, which is what describes most of our patients. And this is the WHO fact sheets, really. We've got an enormous number of people in the world that have got obesity. And that means that this is the prevalence of MAFLD or fatty liver disease, enormously common. And this is now the commonest cause. Over 30% of people in the UK have got fatty liver disease associated with obesity and sometimes a bit of diabetes or maybe moderate alcohol as well. But this is the commonest cause now of liver disease and liver cancer. And it's important when you think about the treatments. Now, it isn't just because, we're all made to feel bad about becoming overweight with the implication that we're overweight, lazy people getting more fatty liver disease because it didn't exist before. And the reality is that actually fatty liver disease, I think, is a disease of a healthy nation. If you look at this slide, most people in the past that had got problems related to their weight or their heart actually died of heart disease. But this has been globally changed. There are such good treatments now for heart disease, treatments for high blood pressure, advice about stopping smoking. People understand this, putting people on aspirin to prevent heart attacks and strokes. And so that means that a lot of people that actually would have died years ago haven't. They're healthier and they're living longer. And so instead, they're getting a fatty liver, which may then progress to cirrhosis and cancer. So what we want really is those interventions that have this big impact for people dying of cardiovascular deaths. We want that for the liver as well. Now, actually, the reality is that a lot of this is things we know. It's common sense. You need to lose a bit of weight. Really important is activity, your lifestyle. Kate Halsworth may have talked to you, and she has really been leading the way, trying to get people to be more active because we know how important that is in improving your liver disease. There are other treatments, metformin, statins, and aspirin. These are things that can prevent progression of liver disease, but actually may also reduce cancer risk. So if you do have one of these diseases that should be treated like diabetes, I'd like people to be on metformin we like you to be on statins and aspirin as well, because there is some evidence, not enough to treat people that haven't got another indication to reduce liver cancer risk, but actually we definitely want you on them if there's another indication. Now, you may or may not have heard, for people that are interested in MASL, of the new treatment now to treat patients with NASH. So this is the first drug licensed by the FDA in America now as something that can help resolve NASH. And this is called resmetirom. Professor Anstey was a co-investigator on this trial. Some patients were from Newcastle. And actually, it's a drug that is a thyroid hormone receptor agonist, something that perhaps stimulates your thyroid system in a way that is perhaps mimicking more active. But this is the first drug to be licensed. I don't think it's going to be approved by NICE in the UK for a while because it's extortionately expensive, but things are changing. So that's a little bit about the background, what we might do for people that haven't got cancer yet. But the rest of this, I want to talk about what we do with patients that have got cancer. Now, this couple here leaping in the sky, they're not real, are they? We don't see people leaping about like that. A lot of our patients are elderly patients with the metabolic syndrome. When you get a liver cancer, the median age is one. If you're somebody that gets a cancer without having cirrhosis, you tend to be older still, but sometimes that's better because you're not so worried about making a person's liver function worse. But you just have to be very conscious that these people have got the metabolic syndrome and they have a risk of a cardiovascular death. They have all of these other things that are being managed and looked after. So they have to be taken into account. Their kidney function, for example, might be a reason that you're not doing as many scans as you want to. They might also be on some of these drugs. If you want to do a liver biopsy, you need to think about them so that you're not making things worse. And I think the other thing to remember always is that in the Northeast, whether or not MASLD or NAFLD or whatever you want to call it, is the cause of your liver disease. Over 2/3 of our patients have got the metabolic syndrome. So if the cause of your liver disease is alcohol, or if it is viral hepatitis, hepatitis B, hepatitis C, still most of our patients have got the metabolic syndrome. And it's associated just with an aging population, with people that get a little bit less active and a little bit more overweight with age. And perhaps drink a little bit of alcohol. So we can't ignore this. It's very important when we're thinking about our patients in the Northeast. This complicated thing here is that Barcelona Clinic for Liver Cancer algorithm. And this is for a person that's got a liver cancer. And then there are these stages, early stage to terminal stage disease. And there's all of this size and liver function. What we're trying to do is choose the patients that are going to have microwave ablation, resection, a liver transplant, all of these things. This is that arterial treatment. And then for those that can't have all this, the systemic treatments that are around. And if you can't have any of these, then you will be having supportive care. Now, the problem is that in addition to just looking at the size and the number of cancers and the liver function, the Barcelona group also looked at something called the performance status. And that was because in their patients, when they had hepatitis C, if they had started to lose weight or they had pain or they weren't able to work, it was because of their cancer. And so they no longer were fit to work, for example. And so performance status 0 is a fit person who goes to work and does everything normally. And then a performance status 1 patient can't do that anymore. Performance status 2 is the person that needs to sleep in the day. 3 sleeps all the time, 4 never gets out of bed. And they knew this was important in affecting survival. And they put it into the staging system. And so this has an impact because it means that if you have rules out. Here you can see if you've got performance status 1, you're automatically called an advanced stage cancer. Doesn't matter whether you've got cirrhosis, doesn't matter whether your liver function is normal, doesn't matter what the size of your cancer is. You're called advanced stage disease, and this arrow takes you through to having these medical therapies. And so this has always been a concern for me because in our older patients with the metabolic syndrome, these therapies can have side effects and they're not very well tolerated. And if you've got a performance status of 1 because you've got a sore knee or something like that that you've had for years, and it has nothing to do with your cancer, you're not getting a treatment over here that you should be getting for your small cancer. So I've never really liked it, and I've always opposed it really, to try and make sure that we do the best for our patients, because this is the reality. In the Northeast, all of these early stage patients are only 20 to 25%. We want patients at that early stage, but most of our patients we get at this stage because of this performance status partly. And so we don't want to treat all of our patients with medical therapy. If they're not suitable for it, they won't tolerate it well, and actually there might be something better. And the other thing is, because people often have a fatty liver disease, we know that people with diabetes who don't have cirrhosis can still get liver cancer. So they might even be able to have a liver resection. We don't want to remove the opportunity. So we don't use the Barcelona Clinic for liver cancer algorithm. We in the UK use our multidisciplinary team. So when a patient is diagnosed with liver cancer, they'll have a specialist nurse and their local hepatologist or gastroenterologist, and they're referred to our tertiary centre multidisciplinary team. And here we will have all of our specialists who know what's available in our hospitals and how well people do with different treatments. And we choose the best treatment for our individual patients. And it's really important if you do this, that you audit your outcomes for your patients, because you don't want to decide you're not using somebody else's algorithm. You're going to do your own thing, but not check actually that you're doing some good. So we've always our care pathways. And very recently, this is just published in the journal Gut this year, we have authored a UK guideline for patients with liver cancer, and it hasn't got restriction centered around the performance status. We basically want to know how good a person's liver function is. The cirrhosis is always going to be important, and whether or not we're going to be able to give them some treatment. And sadly, 40% of our patients are at a stage where their liver function isn't very good. They're not suitable for a liver transplant, and we can't treat them actively. And so they have active supportive care. We don't give up. We try to get them fit enough for treatment. But of these people with earlier stage disease, we try to use whenever we can resection and transplant. We try always to consider those, but we want the best treatment available that our patients can have. And actually, quite often, it's microwave ablation, where we're putting a person to sleep, a small cancer, putting a little needle in and burning the tumor. That's a good way of destroying it, and it's not so big as a liver resection. But a lot of our patients get this treatment, which is the arterial treatment. It's called TACE, which is transarterial chemoembolization. It sounds a bit of a mouthful, but basically liver cancers have got a rich arterial blood supply. Most of the blood supply to the bowel is actually blue blood coming from the bowel here, going into the liver. And so the artery is a sort of backdoor blood supply in a way. You can go, but the cancer attracts its own blood supply artery. We can exploit that. You go through the groin, the person is awake, the groin is numb, up to the liver, you find the artery that supplies the cancer, and because there's another blood supply, it means you can block it off with little beads, and that can be very effective. And sometimes we're able to shrink a cancer. So Dr. Littler may have talked to you, I think, sometime last week. He's our interventional radiologist. He has quite a big cancer in somebody's liver. He's done the arterial treatment, and here he's put the little beads in. The beads block off the blood supply. They have chemotherapy on, But here he's used what we call luminescent beads that are then showing up on the X afterwards. This is a CT scan. And with time, this big cancer had shrunk with the treatment, blocking the blood supply and the chemotherapy. And then he went back with his ablation needle. The person was asleep and he microwaved it. So he actually cured the cancer. And here we know from our audit that the median survival of our patients having this treatment is over 2 years. So that's good. We're not doing harm to our patients. But actually, with that arterial treatment, which I've explained before, sometimes the tumor is big, you don't manage to shrink it like that, and nodules will regrow. And this risk of this treatment is that actually you can harm a person's liver function. And if you do that, they're not going to be fit enough to have any of those other treatments, the medical treatments. So really, we'd quite like to know who's going to do well with this treatment and who's not. And so now for about 5 or 6 years, we've had big trials going on in Newcastle where all of our patients with liver cancer, we invite them to take part in Cancer Research UK funded studies. And the first was called a Neutrophil Program Grant. And recently it's a study called Hunter, which is Hepatocellular Cancer Expediter Network. And we've recruited actually nearly 800 patients around the UK so far. And we don't do anything different to our patients. We're collecting their blood samples and storing them. And some of what we've done is storing them in special tubes called packaging tubes. And these preserve all of the cells in a person's blood. If you could come up with a test that's going to tell you a treatment's going to work, it would be nicer if it was on a blood test rather than actually having to have a liver biopsy. Now, we can do what we call RNA sequencing of all of the genes in all of the blood cells in those tubes. But it's very expensive, and we've got 800 patients. So what we wanted was to ask a very specific question. And because we've got patients that have been recruited and we followed them up for years, some of these patients. So we looked for the patients that had had TACE. We wanted them all to have the same stage disease at the beginning. The person with a bigger cancer is always going to do. The person that's got a multifocal cancer is going to do worse. But we wanted people that had got the same stage. So either one cancer that wasn't bigger than 5 centimeters or up to 3 cancers, but they all were less than 3, that were treated with TACE. They all had to have very good liver function, and they had the TACE, and we had at least 1 year's follow-up. And we wanted to identify those patients that did really well and those that progressed early. And we ended up with around about 50 patients where half had done really well and half hadn't. And then we spent our £400 per sample. And this is Salam, one of our PhD students. This is his PhD. And you end up with what people call big data that we don't really understand, an enormous amount of data, which is all the genes that are expressed in all these patients' blood, but you can put it into different software programs. And this is called cybersortics. And it can churn out the numbers. And what it did was show us that in black here, these were neutrophils, white blood cells. Neutrophils are the first responders to infection in the blood. A lot of changes in genes that were expressed were going on in neutrophils. The different colors are all other different genes that are also in the blood, lymphocytes, T cells, stages. But what we've been able to do is map the different genes to neutrophils in particular. And this is called a volcano plot. You basically get all of the genes that have gone up and down in the people that responded or progress. And on this side in red, these are genes in immune cells that went up in patients that didn't respond, who got the cancer recurrence very quickly. And over here, these are the ones that predicted who was going to have a sustained complete response at 1 year. So these things tell you a lot about the neutrophils in the patients and the immune environment. These ones are biomarkers that will tell us who's going to do well. These are also quite exciting because these are things that we can potentially develop treatments towards. Can we stop this? Can we do something to these things that are there so that we make the patient who has this profile in their immune cells in their blood into this one, so that we can give them a coexistent treatment or make them respond. So that's just one of the research projects that's going on, and I hope at some point I might be able to update people. For people that have got much bigger cancers, this is a huge cancer here and a CT scan taking up really most of the right lobe. You could try and give a person like this a medical therapy, but this person didn't have cirrhosis. And so what Dr. Littler did instead was that arterial treatment, but instead he gave a big dose of internal radiotherapy. This is called SIRT, selective internal radiotherapy treatment. And this is the scan that shows that all that radiotherapy has been sucked into the cancer. That cancer, about 3 or 4 months later, it's hugely shrunk down. And at that point, our surgeons were able to go in and resect the cancer. You couldn't have done it back then because the bit of liver that was going to be left was too small. But what's happened here, as they've treated that left lobe there has hypertrophied, it's got bigger. And now this patient has just got that nice, healthy looking left lobe and no cancer. Any more slides now, but I didn't want to ignore the people that have got more advanced disease where they can't have those treatments, because I've implied that the medical treatments aren't very good, and that isn't true. For a long time, we didn't have any at all. Since 2010, we've been using drugs called kinase inhibitors. Now, those are tablets, so actually the patients like taking them. They don't have to come in and have chemotherapy. They don't need to have an infusion. And for some people, they do actually work quite well. And they don't shrink the cancer, but they slow down how quickly it grows. Now, in 2020, that changed because this was a combination of drugs, an immune activating drug. We keep coming back to the immune system, but this is one that activates the immune system in combination with one that damages those blood vessels, the arterial blood vessels in the tumor. The combination of the two was actually superior in terms of survival than using the sorafenib, the kinase inhibitor. Now, you can recall that when this became the treatment that we were allowed to use, it was 2020, which was the middle of the COVID pandemic. And we were afraid to start giving this immune activating treatment to patients, having to come in and out of hospital. They had to have an endoscopy before you could give this one that damaged blood vessels. And the tablets, you could just poke patients. They could just have the tablets at home. But it was a very lonely time for our patients. But things have changed now. And so when we have a patient with more advanced disease, we're always going to ask in Newcastle, regardless of a patient's performance status, whether we might be better off with our patient giving them a loco-regional therapy. That's the ablations and the TACEs and the TERMs. But we don't want to exclude them from having the medical therapies. If we're going to go for a medical therapy, you need to know if they have an immune disease, because if they do, or they've had a liver transplant, you don't want to put them on an immune activating treatment. They have to have the kinase inhibitor. If they don't, we have to assess their bleeding risk. They have an endoscopy to make sure they haven't got varices. And then we go ahead and give them this treatment. And some of our patients are doing very well. Now, a lot of our patients, there was the 40% we couldn't treat. We give care. And that isn't just, go away and don't do anything. This is dietary advice, getting people to eat better, trying to get them to do a little bit of exercise. We know that if we can improve a person's liver function because they eat better, they will live longer. Sometimes we get patients fit enough to have treatment, so we never give up. And some of our patients took part in this study, Telex liver cancer, and that was run by myself and Kate Halsworth. And we've now published this study in the full version in the British Medical Journal, showing that our patients who got cancer can actually deliver exercise for them. even they don't have to come anywhere. They can do it at home. We did it by Zoom, and a lot of our patients did very well. And we're hoping actually to take this forward, bigger randomized study to reach more patients. Now, for the very last part of this, I do want to just talk you through some more complicated slides, really. And this is showing you survival. On the bottom here, which is we call it the x-axis, is the months of survival. 60 months is 5 years. The blue line, this is all the patients that I saw and audited when I started as a consultant between 2000 and 2010. Now, the sort of average survival of all of the patients, and there were 632, was 10.7 months. The average is here. How many patients survived? 50%. And so it wasn't quite a year. The long-term survivors, the ones that are still alive at 5 years, they're the ones that had the resection and the transplant. But most of them had died. Now, the red line is 2019. That is the year before the pandemic hit. And you can see there has been a big shift. The mean survival, 15.5 months, and more long-term survivors, 20% actually, compared to probably only 10% before. So it still might not be as good as we want, but it's certainly moving in the right direction. And then we had the pandemic, and that was awful because we lost a lot of our patients. They just weren't referred. And because the survival, it wasn't particularly different, that median survival, but we can see now we've gone backwards by 10 years, losing those long-term survivors because most of our patients weren't detected early because we didn't have surveillance, we didn't have our GP visits to detect cancers small enough. But we've turned a corner. The purple line is 2021, but this green line here, that is 2022. And this big shift, this is the impact of selective internal radiotherapy and the new medical therapies for patients with advanced disease. And so this is good news overall. I think that things are changing for us. And this slide here is just showing you the different treatments that our patients have had in those time periods. In 2019 to 2020, the first thing is that we had nearly 200 patients that year. Now, most of them got best supportive care. That's miserable. We had some down here that were getting a transplant or a resection, a lot of patients getting TACE, and a few patients were getting the radiotherapy treatment or the kinase inhibitor, the sorafenib, and this #12 was ablation. This is what happened in the pandemic. First of all, we lost a third of our patients. We weren't giving as many of the earlier stage treatments. We started to use the atezo-bev for the first time because that's when it was licensed. And then in 2021, 2022, the numbers of patients, we're getting them back. We're still missing a few because this is 2023, but we're getting them back. And actually, we're now using more of those treatments. And this surge in the treatments that we have available is the reason we've seen that improvement in survival. And actually, we need to do a lot more work here to be able to get our patients fitter and have more treatments. And this is just referring to a grant that we have got, Quentin Anstey and myself, using the Hunter Registry and the Litmus Registries to work with Giuseppe Lovett, who is the leading investigator from the Barcelona Clinic for Liver Cancer. We've got a big EU grant to actually use all of our patient samples to try and work out ways to detect liver cancers earlier and also how to use the best treatments for the patients that have got liver cancer. So this is my last slide, just thanking everybody that takes part in this work. Derek Manus, I'm sure many of you will know, was always my mentor, and he helped me set up the liver cancer program back when I was appointed in 2003. Peter Littler and Georgia Priona are our outstanding interventional radiologists. And Louise McDougall is now a hepatologist alongside me looking after patients with liver cancer. This is the team, and we got one of our big grants. And then down here are all the research team and the students. And there's Nicola, who's our nurse, Ian Parker, who's our patient representative for some of our grants alongside Joan and John. So that's me. I'll stop sharing now. And if anybody has a question, I'm very happy to answer it.
Well, excellent. You went through a lot there, Helen.
I did,
Fantastic.
yes, I did. I'm sorry.
No, that's absolutely wonderful.
I didn't want to leave anybody's treatment out, just in case somebody was to listen and wanted to know about their own treatment.
Yeah. It's amazing the advances. The the giving people therapy, clinical therapy, whatever stage they're at, seems to reap benefits, hasn't it?
Yes, I think so. There was some worry that these new treatments don't work so well for people with NAFLD.
Mhm.
Um, but actually, we don't think that's true. We've seen quite a lot of our patients do really well. The sad thing is that when we have the treatments, it's sort of a bit like a third, a third, a third. About 25 to 30% of patients to that combination get almost a complete response. Their cancer shrinks and they live for years and years. And then there's a third that get a stable disease. So it doesn't shrink, but it stops growing for a while. Then a third get no benefit. So although it's marvelous for a third. And we still have 2/3 of our patients where we haven't got that wonder drug. And a lot of the focus at the moment, especially with the work we're doing with Giuseppe Lovett, is really trying to work out um, the way to predict who is the third that responds, because you don't really want the people that aren't going to respond to have to get the risk of side effects and complications. And actually, you'd quite like them to be well enough instead to try a different treatment, a different combination. And with Derek Mann and Jeff Evans from Glasgow and a big UK consortium, we're hoping to come up with different ways to approach immunotherapy, different ways. If that immune system wake up doesn't happen for whatever reason in 2/3 of people, we want to work out why so that we can get it to happen in more people. And that's probably the way forward for treating many cancers, not just liver cancer.
That's excellent. So, Yvonne, you've got your hand raised and you're muted. There you
Yeah.
go.
Thanks, John. Can you hear me okay, John?
You're very quiet.
Oh, I'm very quiet. I'll come closer. It's a bit of a frightening picture if I come a little bit closer. Can you hear me
Don't
now?
worry about it.
No, Helen, thanks ever so much for that. And I certainly really appreciate it, and certainly appreciated and was shocked by what happened during COVID with our people, with the people who had the potentially liver cancer. I just was interested, when you were talking. I'm someone with MASH and stroke cirrhosis, and I have seen you in the past, actually, at very early stages, Helen. I was sent to your clinic by mistake, and in
Oh,
actual fact, it was a blessing. It actually turned out to be a blessing, Helen, which was really bizarre. But that's a long story. But one of the things that hit me there was the genetic side. So it for me at my stage, I've got all of the I get the scans, the ultrasound scans, and I get monitored on a 6 monthly basis. I'm fortunate from that point of view. But if you're hoping to get earlier, those sort of that doesn't happen with the earlier stages in terms of NAFLD or MASLD. But
there's
from the genetic point of view, which is what you're saying, is there a chance of picking people up even earlier just from using those genetic links?
what we want, this grant that we've got, Quentin Anstey and I, you most likely are part of his litmus registry.
I am, yeah.
So that is a registry where he has been recruiting patients with fatty liver disease and then following people up like he has you. And you will have had a biopsy. You will have had some blood samples taken. Now, the purpose of litmus is to identify the predictors of progression to cirrhosis. So most people in litmus have not got cirrhosis, but there are a proportion of people that do. And so there you have an opportunity to do all of the studies looking at genes or proteins in blood samples and comparing the patients who've got cirrhosis to those that haven't got cirrhosis. And you come up with the things that are associated with the development of cirrhosis. Now, the grant we've got from the European Union is to repurpose his registry, but to identify the people within litmus that have developed cancer. And we know that there is 40 of them so far. We are likely to then be able to bump up the numbers with patients in the Hunter registry who have got liver cancer but have had a previous biopsy or been followed up in a different clinic, so that we can do these studies. And we're about to do the genetic study. We've got 1,000 patients with hepatocellular cancer, of which 450 are NAFLD, and we'll be able to compare that to the patients that are matched in Quentin's registry who have no cancer. So we're going to find the genes. That this will be the thing that stratifies risk. You as a woman are at lower risk of developing liver cancer. The risk for a man is higher. But the cirrhosis elevates your risk whether you're a man or a woman. But knowing the genes might be an extra thing that will help. And really, you want a test that's going to detect the liver cancer earlier. But if someone's got a risk that's, 50-fold over a 5-year period, you might do the scans 3 monthly, whereas someone's risk is like 0 because they've got none of the genes. They're a woman. They haven't got cirrhosis. There's no point doing surveillance in that person. You need to be able to stratify the risk and better tools, hopefully, at some point.
That's interesting, Helen. Thanks for that. My daughter, who's 40, is one of Quentin's patients as well, just recently been diagnosed with MASH, stroke, cirrhosis, and she's only 40. Yeah. So when you're talking about genetics, that sort of hit me like a ton of bricks. So but thank God she's one of Quentin's patients now. So anyway, thanks, Helen. Thanks ever so much. Thanks, John. Thanks.
Right. Well, thanks for that, Yvonne. We've got Valerie, you've had your hand up.
Yes, can you hear me?
Yes, can hear you. Yes.
Hear me. Good evening, Professor Helen. My husband was one of your patients, September 2019 to March 22. I don't know if you remember him. He's still surviving, and he was looking forward to thanking you for all your help and care tonight. But unfortunately, he's suffering from a bad case of cellulitis in both legs. And so admitted to hospital yesterday, but he wanted me to sort of just give you his thanks for helping him so much. After he finished treatment with yourself in March 22, he had 6 months of sofenirib, and he was very, very poorly with that, very desperate, and ended up in hospital with sepsis. And so he stopped taking it. And thankfully, he's surviving. So come September,
that's the thing. Sometimes people want to try something, and at least with the tablet, you can try it. And if it doesn't suit you, you can stop it. And you feel like you've had a chance at trying something. But the reality is that for a lot of our patients, it's focusing on their diet and getting their protein level up, and eating more of those things, and trying to be a little bit active if you can. Cellulitis is hard, isn't it? Because it restricts your mobility as well. but I think that supportive care I didn't show the actual evidence really with our survival for our patients, but just optimizing supportive care in our unit now for people with no hope, who've got very poor liver function. Our median survival is 6 months. People have had no treatment at all, whereas actually in that algorithm, it's 2 months, 2 to 3 months. So I think that it's really important to just not give up and keep doing everything you can. And for him, he's got you. So,
I'm very careful with his diet, and I had the tears and the ablation with yourself, and then after with the sorafenib, it was just so poorly. He couldn't eat much, and he was losing lots of weight. And then we turned a corner after he came off it, and he's had quite a good healthy diet since.
maybe it changed something in that immune
Thank you
environment.
very much for your help and being so supportive and explaining every procedure so very well to us. We thank you very much for your help.
Thank you.
That's excellent, Valerie. Thank you for that. It's not often that clinicians get a feedback, a live feedback anyway. Unlike car salesmen who have their desk littered with cards saying thank you, which are all rubbish. The clinicians don't get many cards.
But
But
Ken just really sings your praises. He does.
well, that's lovely of you. Thank you.
Thank you.
Any more questions, anyone? You're okay? Well, that's excellent, Helen. Thank you so much.
I've enjoyed it, John. It's very nice to see everybody.
Well, that's good. Now, don't forget we're here, and if you need any help at all, please ask. We're here. It's our job to help the clinicians and to help the patients. And whatever you want, don't hesitate to ask. Okay?
Yeah, the worst we can say, Helen, is no,
That's right.
which we wouldn't want to.
Okay, folks, I'm just going to flick the screen to show you the poster for the next meeting. Shout out if you can see it. Can you see that? No?
No.
Wait a minute, I'm going to do it now. There.
Oh.
No one can see it. Okay, it's Rachel Howarth and Thomas Crame, Nutritional Considerations in Liver Disease, with questions and answers, and that's on the 25th of July. Okay.
Well, that's one definitely to go to.
Yeah, it'll be great. And no doubt they'll be saying, like most people, they hate telling patients to eat less and take more exercise, but that's what they're going to tell us. Okay, folks, I'll end it for everyone now. I'll just stop recording.